Dear viewers, welcome you all to our show, Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and by taking vaccine. Dear viewers, today our topic is humerus. That means llizarov in humerus, the safe zone, corticotomy, and wire fixation. Very important topic for all of us, for all the orthopedic surgeons. And I would like to remember those martyrs who sacrificed their lives for our beloved mother tongue, Bangla Bhasha, in 1952, in the 21st February. As because of them, 21st February is the International Mother Language Day. I proudly declare the International Mother Language Day is only for the Bangladeshi people. I show my gratitude and salute to those martyrs and their families. Dear viewers, the humerus, a very complicated bone, and the llizarov, a very interesting thing. And our honorable speaker is Professor Mofakharul Barrister, the legendary llizarov surgeon from Bangladesh. Thank you, sir. Thank you for joining us.
Thank you very much for good introduction. Thank you, Tanveer.
Thank you, sir. And dear viewers, we have another highly academic expert panel from Russian Institute of llizarov, that is the Professor Novikov, sir, a well-known scientist
Good
in
afternoon.
llizarov arena. Good afternoon, sir, and welcome to our show, Orthopedic Solution Academy. Dear viewers, we always face some difficulties and challenges. I don't want to say difficulties as because of there is llizarov. So if there is any challenge, we can face the challenge by llizarov. And in case of humerus, llizarov is an excellent option. And we will show how we can fix the wear, where we can do the corticotomy, the safe zone, and many other things. You can join with us in the chat box. Now, I would like to request our honorable speaker, very learned person, and very affectionate person also, Professor Mofakharul, sir, to start his nice presentation. Professor Mofakharul, sir.
Thank you. So, I am visible, eh?
Yes, sir.
Good afternoon, everyone. And really, Tanveer, tomorrow is our International Mother Day. I would like to show respect to the martyrs. This is also International Mother Language Day. So with this, I want to start my topic regarding the llizarov in humerus. So this is the center. See, beautiful in summer, you can see the Kurgan, the orthopedic capital. This is our institute, 1,000 bedded in Dhaka. I always show this one. And this is where I'm working now in two hospitals, in diabetic hospital and BH hospital. And this is my center where I'm doing a lot of llizarov. And this is I myself with other distinguished professors. llizarov, the man, the myth, the method, and the magician. I always show this one. Now let us talk about the safe zones or corridors. Last time I talked about the femur. Today I'd like to talk about the safe corridor in the humerus, as defined as longitudinal regions through which wires and pins can be inserted safely, for they contain neither musculotendinous nor important neurovascular structures. These are easily identified in eccentric bones as regions where the bone can be palpated subcutaneously. If you think about the preoperative planning, all the cases are assessed thoroughly and examine the causes of the failure. And we must see the associated problems like deformity, shortening, and the joint stiffness were documented. And all the patients were explained about the problems that are facing in their day-to-day life and the treatment procedure, the post-operative protocol, we must tell to the patient, and of course, at home, how they will lead their life with llizarov apparatus. post-operative management and rehabilitation. This is also very important. Shoulder and elbow exercises were encouraged just day after the pain permitted. Cleansing the pin sites at regular interval and discharge with follow-up every week until radiological signs of union you can see. And apparatus removed with outdoor or indoor basis. So what will be the position of the patient when you are going to put llizarov in the humerus? Look at the two pictures in the top and below, position of the humerus in OR. You can see skeletal traction is applied through the olecranon process. See, this is a device that we are using all the time when putting llizarov apparatus in the humerus. Now let us see the anatomy. Every orthopedic surgeon or reconstructive surgeon should know the anatomy of the region where he is going to apply the apparatus. Humerus is located in the upper arm and between the shoulder joint and the elbow joint. Shoulder joint, also known as the glenohumeral joint, is a ball and socket joint. The ball is the humeral head and the socket is the glenoid of the scapula. The joint is supported by four muscles, very important: infraspinatus, supraspinatus, teres minor, and subscapularis. These muscles originate on the scapula, and this is inside of the humeral head. Now look at the anatomy. If you see at this, these are the neurovascular structures. From medial to lateral side, deltoid muscles, and all the branches of the axillary vein, cephalic vein, anterior circumflex humeral artery, ascending branch of the anterior circumflex humeral artery, and musculocutaneous nerves. So now, before putting the apparatus, you must see the long head of the biceps. You can palpate with your hand, with your finger, and you can identify. And make sure not to fix this structure to the bone with pins or K-wires. This is very important. You see the axillary nerve here. You can see how to identify the axillary nerve. The anterior border branch of the axillary nerve crosses the humerus horizontally about 6 cm distal to the lateral border of the acromion. This distance does not significantly vary and is reliable. To protect the axillary nerve, mark the skin 5 cm. You look at this here, 5 cm and 7 cm distally to the acromion. You look at this here. This is very important. 5 cm. If you add this 2 cm, here you can see the axillary nerve. And the lateral aspect of the proximal humerus, proximal and distal to the corridor, can be regarded as the safe corridor. Now let us see the safe zones. Safe zones or for wires. You can see wires are inserted from the lateral through the deltoid muscle, or you can put it from the anterolateral to the posterolateral. Our wire insertion, the tip of the wires in the humerus shaft should just perforate the far cortex. Look at this here. You can see here, this one. And if inserted too deeply, you can injure all these vessels. So be careful about this one. Now we can use all the time. We are using first one. This is the olive-like. Sometimes this is olive-like. Concept of cork screw-like. You can make it by the smooth wire, and you can make the bayonet wire. Whenever you don't find any olive wire, olive is of course better. Then you could use this kind of just like olive and this kind of bayonet-like wire. So these are the important things. And this picture, what I'm showing to you, this is the scheme for insertion of the wires in the humerus. You see left side the 4 pictures, and the right side the 4 pictures. Look at these. If your fracture is here, you can see, you can find out how you can put the wire here, and what will be the position of your hand. What is the position of the hand? If you go from this side, see, you must flex your elbow. If you go from this side, you must flex your elbow. This is 2 crosswires, and go through this one. See, if you go from this side, this will be extended. If you go from this side, this will be extended. This will be extended. This will be extended. This is very important for insertion of the wires. So now, if you look at the level of the wires insertion, we have divided into 7 parts. One below the head of the, above the head of the humerus. Next one is the level of the humeral head, number 2. And number 3, you can see here the level of the surgical neck of the humerus, upper third of the humerus, middle third of the humerus, and this is lower third, and this was the level of the humeral condyles, epicondyles. So now regarding the cuts, we can divide this into 6 cuts. You must think about these cuts. If you think about the first cut, look at this, how to put the wires or shunts this way. Second, cut 1, look at all structures. And truly you can see the all vessels and nerves and muscles. So you should have to keep it in your mind when you are going to put your wires or pins. Now cut 2, placement of the hub pins. You can see the direction. This is the muscles you can see. This is humeral surgical leg, deltoid muscle, big one, this one. And these are the all medially, what are the structures you can see here. You can see here. Now cut 3. A fixation wire can be placed from anterolateral to posteromedial. This is a safe, transversing both the biceps and the triceps muscle. A hub pin is inserted anterior to the radial nerve from anterolateral to posteromedial. This is also very important. You can see the cut level 3. Now structure of the cut level 3, all the muscles you can see, biceps, brachialis, this is a humerus, and the nerve vessels, and of course the muscles also. Now next see the cut 4. Cut 4, this is not too much dangerous. A fixation wire can be placed in an oblique direction from anterolateral to posteromedial. Always, if you think about the humerus, your anterolateral and posterolateral is always safe. Medially, you must be cautious regarding the radial nerve from posterior to anterior. And this is the muscles of the cut 4 and other neurovascular structures. Look at the cut 5. Cut 5 is not a dangerous area. You can fix the wire by looking the vascular structures and the muscles also. See the direction of the wires and the pins. And this is muscles and neurovascular structures. And this is cut 6. Distally, you must remember regarding the 2 condyles, medial epicondyle and lateral epicondyle. See the direction of the wires, crossing of the wires. Wire placement at this level is best achieved in the coronal plane. The reasons of this are the bone is oriented in this axis, and this plane about the dorsal and ventral neurovascular structures. Whenever 2 wires may be inserted at this point, the first wire is inserted via the medial epicondyle. During this insertion, you must see the ulnar nerve. Whenever you are placing the wires, you just push your ulnar nerve laterally so that you cannot hit the ulnar nerve. And this wire should be exit anterior as is possible to the lateral condyle. It's very easy to passing from medial condyle to lateral condyle. These are the cut 6 structures, the muscles, the neurovascular structures, and the humerus distal end. So these are you can see here, these pictures I have taken from Kurgan, all diagram for wire insertion at the level of the coronoid process and neck of the scapula. You can see marking the all muscles here. This is at the level of the coronoid process and neck of the scapula. This is at the level of the humeral head. See the direction of the wires, angle 20 to 30 degree. And K1 is the humerus, K2 is the scapula. These are the identification muscles. When you will go for insertion of the wires, if you do 1 or 3 or 4 or 5 cases, you will understand in which way, in which direction you should have to put the wires. So this is regarding the humeral head wires passing. This is the surgical neck. Even you have a surgical neck fracture, you can put the wires in this direction, see 35 to 40 degree angle without injuring any neurovascular structures. And this is, you can see at the upper third of the humerus. You can see the direction of the wires. Your angle will be 40 to 50 degree. And at the level of the middle third Middle third, you must be a little bit cautious regarding the radial now. See, you can make an angle with the wires 30 to 35 degree. And lower third of the humerus that I told you, you can put 10 to 20 degree angle or 15 to 20 degree angle. So diagram for wire insertion at the humeral epicondyle. This is the humerus. You can see this is the humerus. How you can put the wires. K1 is the distal epiphysis of the humerus, and you can see the marking K2 is the medial epicondyle, while you are going from this here, and M2 the lateral extensor of the wrist. You can see here M2 the radial extensor of the wrist. So in this way you can put the wires. And corticotomy, this is a low energy osteotomy with the preservation of periosteum, endosteum, and bone marrow. So whenever you are doing corticotomy, you must choose the level. You must see the anatomic, biochemical, and physiological factors. And anatomical factors also in the middle of the bone. Corticotomy is suitable in between the diaphyses and beginning of the metaphyses. And sometimes you can do it in the diaphyses also. These are the biomechanical factors. Bone segment must be large enough to accommodate two rings situated between the bone and the bone transection. Appropriate distance must be 4 to 6 centimeter. For humerus, you can go for a little bit less. And these are the physiological factors. Preservation of the periosteum, endosteum, and bone marrow. You must maintain the local blood circulation, and you must see other things also. And common mistakes that time I told you, don't go for too large skin incision. Poor choice of the corticolevel level. Use of oversized osteotope, and you don't need to go for destructive hammering of the cortex. And direct cutting of the bone marrow canal. This is very important. Then as a result, it will disturb the vascular structure of the medullary canal. Injury to nearby vessels is nerve. You must be very cautious. And sometimes when you are doing corticotomy, if you don't rotate, you can see you are getting an incomplete corticotomy. And avoid traumatic corticotomy. Look at this. Patient with humerus. See how he is doing exercises. See, patients are doing exercises. This is in my center. See what kind of exercises they are doing in humerus. See, no difficult, interesting. So you must advise your patient after putting the llizarov apparatus so that they persistently continue their exercises. Okay. See, look at this. In the upper part of the humerus with fixator. This is distal third of the condyle. See, olecranon fracture probably, and he is doing exercises. So I suggest all my llizarov patients, always you must do sincerely the exercises. See another one with humerus, and this is right sided, left side you can see in the humerus and radius and ulnar at the same time. Look at this young beautiful girl doing exercises, lengthening of the humerus. This case was 30 centimeter shortening, post-traumatic shortening, post-osteomyelitic shortening, post-septic shortening of this case. Now see here what they are doing. Exercises. She's trying to put her hand to the mouth. Now I would like to share my some cases here so that you can understand. See, this is a patient of 78 years old, surgical neck with greater tuberosity fractures. You can look here. Next, see how I have put the apparatus, llizarov. This is mini llizarov. You can see this is not full llizarov. See one ring here, and I have captured all the fragments with olive wires. Now let's see, after 3 months follow-up, 70 years old gentleman, clinical appearance of the patient, and this is before, this is just after. If you think about the needs classification, 5 types. And look at this 28 years old gentleman, open fracture, dislocation of the right shoulder. If you look at the radiography view left side, you can see here CT scan in the right side and fracture dislocation. Look at this. From externally, we have put this one arch up, one ring below, and multiple K-wires. This is before and this is after. Fracture dislocation, near type 4. See, 40 years old male, open fracture, greater tuberosity, neck of the right humerus. Look at this greater tuberosity. Now, see, we have fixed, and at the same time, he had a problem with the left hand. It was a Smith fracture also, and we have reduced that one. And finally, you can see this is before, and this is after only 3 months clinical appearance of the patient after removal of the llizarov apparatus. Look at this young boy, chronic osteomyelitis. Dear friend, you can see here, upper third of the ear, bone quality is not good. This is angulated, sequestrum. What we have done, just only we have put the llizarov apparatus with smooth K-wires and olive wires. And see, after that treatment, the union achieved good consolidation here. You can see here, look here, this here, and he can elevate easily his shoulder. So this was published in American Medcraft Journal. Look at this hypertrophic nonunion of the right humerus. I'm showing you the different cases in the different places. Of course, you can go for the open reduction, plate screw, bone grafting. See what we have done? Just only with 2 shunts up arch and 1 ring below. I have distracted this one, this hypertrophic nonunion, and look at this final follow-up after 4 months with full consolidation. Hypertrophic nonunion, you don't need to go open. You just go for distraction, or sometimes you can put compression, accordion method, and go for distraction. This is also published in American Journal. Look at this nonunion deformed left upper humerus. Again, you can see what we have done. Only put the llizarov wires, nothing else. And a patient is doing exercise with the dumbbell in the left humerus. And this is, you can see after foot correction, deformity, and union. Implant failure, these are the common scenarios everywhere in the world, not only in my country. Look at this, it may happen. And remove everything, only the wires, only Russian technique, llizarov technique, what llizarov was doing all the time. See, look at this. And this is the final follow-up after the treatment, ring after removal. This is simple case of the fracture. We can do whatever you like. Now, see, if you have only 2 rings and 1 post, see, union is achieved. Look at this, gastro 3A. If you llizarov in your hand, then you can solve this problem. Grafting was done, fixed with olive. You can see it and smooth wires. And this is follow-up only after 5 months. Look at this 68 years old lady, implant failure. You can see the humerus and at the same time non-union. 60 years old lady, bone quality is not good. You cannot go for bone grafting or plating again. So removed, fixed with llizarov, and this is the final follow-up. You can see left side and the right side. This is also published in Russian Kurgan journal, and with lot of cases again in Medcraft journal, the humerus non-union. Look at this upper part of the humerus, atrophic. See the head and the head just here. You can see here. This is the atrophic, pointed this one, and this is one. What you'll do? The bone quality is not good. There you go. See this young child, put the llizarov, and we achieve the union. only a little bit restriction of the movement, because before coming to my place, she has done 3 or 4 times surgery in the same case. As a result, fibrosis was present at that time, and now she's good, she's okay. And 70 years old girl, post-septic, 11 centimeters shortening of the left humerus. You can see here, left side and the right side just compare, and post-septic, 11 centimeters shortening, left humerus. If you see from the front side, the back side, you can easily identify during treatment, bifocal or bilocal corticotomy I have done to achieve the 11 centimeter shortening. Beautiful girl. See, now during treatment, and full length was achieved after the 9 months of treatment. And you can see she's doing exercises. And after 10 months, we have removed the apparatus, doing exercises. Now you can see left side before treatment and the right side after the treatment. Also, this is published. Whenever I do anything new or something interesting, I try to keep it in publication so that it gets authenticity, that this is the way that you can go for treatment. Look at this fibrous dysplasia of the left humerus. Whole bone is gone. I have put multiple K-wires, fixed the wires, and allowed the patient fixed to the wires and allowed the patient to go for exercises. Fundamental load principle of llizarov in load and motion. If you do the exercises, you are increasing circulation and you are strengthening the muscles of the bones. And you can see what he's doing. Only the lot of console wires I have put, the wires that have gone from one cortex to another cortex, and fix this with llizarov. And you can see, just compare, dear friends, after 5 months follow-up by llizarov. We don't need to go for any bone grafting. Bone grafting for fibrous dysplasia, I have never done in my life. And this is not the real way, definitely treatment not for getting the fibrous dysplasia. Too much bone, or if you take the osteogenic bone, that is the shower bone, non-osteogenic, you will not get a good result. You can invite the refracture and you can get non-union of that fracture site. Look at this. Treatment was done elsewhere with multiple K-wires and circulase wire. Look at this. Came to me, 60 years old lady. Remove everything. And look at this. Beautiful healing. She's happy, smiling. Cubitus valgus. Now I'm going to below the humerus. This is the way you draw the lines, do the opening wedge. You can see very easy. Only you have to meticulous. You should have to calculate, nothing else. So look at this. Opening wedge, then after treatment. This is also published in American Journal. Keep it as virus. Again, you draw the angles. Opening wedge osteotomy. You got correct rotation. At the same time, look at this, what I have done. And look at this lower border of the humerus. After full correction, the left cubitus varus. This is also published. Look at this, related to the humerus, Dutch olecranon fracture. 7 years old girl. Just see. After treatment, these are all COVID period. See, elbow restriction with hinges. These are the other cases. See what they are doing. Exercise. llizarov with llizarov, you can do any kind of rotation in different directions so that stiffness you can avoid. And these are my foreign fellows. This is my Nigerian fellows. I am taking their classes in my center. This is the man who made it all possible. Great scientist, talented doctor, gifted innovator, creator of the apparatus and the method of the transosseous osteosynthesis, Russian Academy of Medical Science, Professor Gabriel Abramovich llizarov, friend of orthopedics, created a very, very wide things in medical science. And these are my mentor, Professor Shipsop, and region director Gubin. Challenges in life comes in three categories. I always tell this one: easy, difficult, impossible. Most of the time, I am going for difficult, impossible cases. And dear friends, our life is always a challenge. And by llizarov technique, you can do a very difficult, very challenging cases if you are meticulous and if you love this technique from your heart. The errors that we should keep in mind in post-operative period: unreasonable frequently changing the fixator, non-observance of deformity correction rates, the absence of timely X-ray control of the dynamics of bone regeneration, incorrect interpretation of X-rays, premature removal of the fixator, and underestimation of the importance of exercise therapy and the possibilities of early limb weight bearing with the fixator applied. And Professor Novikov will talk regarding the complications. Of course, every surgery has got the complications. And in llizarov case, you are getting inflammation of the soft tissue, the site wire skin interface. And this is very nicely you can tackle. And post-operative neuropathy sometimes for the peroneal nerve, if you don't know the proper putting of the llizarov or K wire through that place, and consolidation in osteotomy site. Cutting wire sometimes it happens, and you can easily tackle that one. And sometimes when we're going for distraction, we are getting equinus of the foot. And to prevent that, you do all the time exercises. And to prevent knee contracture, same thing with hinges or doing for exercises. And sometimes you are getting pseudoarthrosis formation in case of, instead of leading the pseudoarthrosis. And if you don't put your hinge in the proper way, you can invite the subluxation of the joint. And of course, the transformation of the regenerated bone. And these are my foreign fellows. And this is in COVID period. Still, we are working with the different difficult cases. And this is in my center. All my patients are happy. Now, almost I am going to finish my topic. This is, you can see in COVID period, my patients are still here, and a lot of difficult cases we are tackling with this llizarov technique. I am always grateful to this great man and the Kurgan Center that I've learned a lot of things from their center, and I am using in my day-to-day life and getting good and fantastic results. And always I tell to carry this home message, because we should not close our eyes whenever we see anything. This is the evidence that I've shown you. And of course, it is related to the science, dear friends. And of course, the art of the surgical skill of the surgeon. Technology is very good for machines like computers and telephones. But in human body, we need to go a step further. That is called biology. And we can maintain biology by llizarov technique. And let us be the leaders in advocating biology and cost-effective techniques the globe might appreciate. And we can do that in my country. And in Bangladesh, we have a strong foothold regarding the llizarov and, of course, in the world arena. Thank you so much for your kind hearing. Here you can see the all great people from the Kurgan Center. We had a llizarov conference 2019 in center, and all giant, our giant Professor Shamsuddin, and all giants from Kurgan Center is here, including my spouse. And finally, but not the least, I convey my gratitude always to Gabriel Abramovich Elizarov and Professor V.A. Shepsov, and of course, my friend Novikov also. And from them, I learned a lot of things. What I've learned, the discipline, the way of thinking.
Dear viewers, I think Professor Mofakarul Bari sir is disconnected with us. I think it was an excellent presentation regarding the humerus. We can learn many things from this presentation, especially the safe zone, the corticotomy, and definitely how we can fix the wear. And the most important thing is the post-operative rehabilitation. If we don't do the physiotherapy or exercise, we cannot achieve our goal. Now, I would like to request our honorable academic expert panel to share something or to share his valuable knowledge. There is a noise. There is a sound noise there.
Did you listen to me?
Yes, sir. We can hear you, but there is a noise. Would you please?
Just a moment.
Yes, sir. Now better, but your voice level is a little bit lower. You can make it a slight higher so that we can hear you properly. Your volume, we cannot hear you, sir, now. We can hear you, but there is a noise behind your voice.
Very sorry. I don't know how I can. Maybe this.
Okay, okay. This is okay, sir. You can, yes, sir.
Now better.
Yeah, now it's better now, sir.
And when we touch patient with humerus, surgery very important, but this is only part of our treatment. And when doctor finished, after 2-3 days, must start treat this patient with physiotherapist, with exercise. Because without motion of the elbow joint, of the humerus joint, we cannot get excellent regenerate. And llizarov technique with humerus give us possibilities to treat so many difficult cases like congenital disease, like trauma cases, like post-trauma deformity or shortening. And today Dr. Bari show very difficult cases, very heavy cases. And on the end of his presentation, he show complications. I am a little bit not agree when we talk about complications. What is it, complications? This is something's happened and will be with patient all of the life. If during the treatment, any difficulties, any problem come, but with llizarov, we can go away from problem, from infections, including infection, because we can remove this wire and forgot about infection. And on the end, we haven't any bad memory for the life. This is not complications for me. Next topic, I want to ask you about complications, and I want to show when we talk about complications and when we talk about difficulties. And with humerus, if young doctor won't start, because when experienced doctor show pictures, imagine like very easy, but very each step very important. And just now some patient sent me x-rays on the end of lengthening, and mother of this patient asked why my baby cannot move in the humerus joint. And when we see and when we check X-ray, doctor did osteotomy too high, and pectoralis with lengthening go down. And for all of the life, this baby will with severe problem, and I can call this complications. Doctor like Barry or any experienced doctor already has difficulties and complications. And please, young doctor, use this difficult knowledge about complications, and this give you chance not repeat, because better study, better read about complications than take complications from your hand. And this is very excellent opportunities for us when we can share our experience, when we can share our X-rays, when we can show our cases and ask what you think about, what I can do. And doesn't matter who will see, because sometimes I saw in my experience when llizarov show X-rays and ask experienced doctor, ask what you think, and this is doctor answer. Then llizarov ask young doctor what you think, and young doctor answer with funny opinions. But after a few months, after short period, after this funny propose, llizarov treat new patient with excellent new technique, and some new step will from young doctor. And we invite all of doctor from Bangladesh cooperate and share our knowledge, because we're our future.
Thank you very much, sir. Thank you very much for your encouraging speech and valuable information that where we can do the corticotomy and what will be the complications and what will be the challenges. Dear viewers, Professor Novikov sir will show us some complications and the challenges in the next Friday, and definitely the total Kurgan Center, what they're doing in the that Kurgan Center, and what is the magic of llizarov in Kurgan. And definitely Professor Novikov sir will show us in the next episode in coming Friday. Professor Mafakarul, yes, Professor Mafakarul Bari sir joined with us. Sir, I have a question. Because of in case of open fracture of humerus, can we put llizarov before skin grafting?
Before skin grafting? Yes, why not? You can use, if your wound is very big, you put 2 rings, upper side or lower side, and keep it with telescopic nail or long rods, and keep the space. Only 2 rods you can fix that one. And the open wound, you can keep it. You can put the skin in that place. No problem.
So does it help in case of wound healing?
llizarov, yes, always,
yes,
always,
sir.
always. Because multiple K wires, you're using the K wires. The properties of the bones are 3: isoelastic, hydrostatic, and pneumatic. The wires that we are using in llizarov apparatus, that is isoelastic, just like coincide the properties of the bones. When you are applying tension and you are drilling, you're increasing circulation. That's why the law of tension and stress, llizarov, the llizarov himself discovered this law of tension and stress. Slow and steady traction on a living tissue creates a stress which is metabolically activated, and which stimulates histoneogenesis. Histo means this is skin, muscle, nerve, vessels, angiogenesis, neurogenesis, myogenesis, tissuegenesis, dermatogenesis, every genesis, all genesis. This is the beauty of llizarov.
Excellent information, sir. Sir, I have one more question, sir. As because of we have lots of road traffic accident patients in our country, so we found that there is a bone loss in case of humerus. Can we give skin grafting during a bone loss segment in the bone loss segment, and after the skin is healed, can we put llizarov and we can lengthen the bone over the skin? Is it possible?
Yes, you can do that. You can do that. We are also doing that. We can do that. Initially, you
Okay.
put the one or two rings, just keep the stable bone. And if your wound is very big, there is no infection, then you can go for skin grafting. And then gradually you can go for lengthening second, or you can put another 2 or 3 rings, then do the corticotomy, go for lengthening. And every steps will tell you what you should have to do.
And Dr. Barry, can I little bit add you? Because
Please,
sometimes we have a very strange case when patient haven't any damage of bone and only big defect or big damage of soft tissue. And plastic surgeon invite us and ask, please, and call, please put on llizarov. For what? Because we will cover this area, and then all of soft tissue will reparate more easily, more quickly, and more smoothly. And now we have more better results than before when plastic surgeon work without us. And sometimes we have severe problem like scars, and we start stretch, we start lengthening, and very difficult, and have some problems during the treatment. We invite plastic surgeon finish his job, then we start inside of llizarov frame, and we have situation not like victory, because alone is alone, this is 11, not 2. Result will more better than we work separately.
Thank you, sir. Thank you very much. I learned 2 things. This is not 2. This is 11. That is very important thing. Yes, sir. Sir, I have one question to you. You said you work with the plastic surgeon team. So can we put llizarov just after doing flap in case of bone defect?
Yeah, very often we put flap, and before treatment we very good exam, make plan, and during the treatment usually I am second. First plastic surgeon finished with flap, then I am continued with device. Very often.
In the same day?
Same day. Simultaneous. Same day.
Simultaneous. Okay. Then what about the skin graft? Do you complete the skin grafting in case of flap in the same day, or you will do the skin graft after some day?
This is depend of case, because many times we put, if this is possible, skin graft same days, but sometimes we need prepare after 1 month finished with skin graft, then finished with, this is depend of case, and I think we will select all of this patient with soft tissue. Very interesting. Not only humerus, humerus, tibia, femur, and then we will, I think, must to do a webinar with problem soft tissue, including apparatus llizarov. Major topic. I think never in the world, because doctor, plastic surgeon, all time work with separate. I talk with some doctor, who first? And traumatologist answer, I put frame, then I am invite plastic surgeon. How?
Yes.
Impossible. This is very delicate area, and soft tissue is soft tissue. This is our blanket. And when finished plastic surgeon, then I am continued his job. result is better because inside of llizarov very difficult work for plastic surgeon. And just now we have perfect experience with shoulder-to-shoulder work with plastic surgeon. Today I sit here and some doctor support for plastic surgeon. He start very easily, very seldom. I think this is first time in the world when big defect of clavicular, many surgeries, bone graft haven't result, and just now inside of translate, breast, all material from breast put on here, and then put on llizarov frame. But we are prayer, maybe we will get result, and next time we will show that.
Thank you, sir. Thank you very much. We also pray for that patient. Sir, to Professor Mofakharul Barik, sir, I have some own experience in case of humerus, and I want to share that thing, sir. I face always difficulties in case of corticotomy, in case of humerus. I was a little bit afraid to do that corticotomy. Sir, would you please help me to find out the perfect place of corticotomy in case of the humerus? I think it will be the last question from mine to you.
See, you can do corticotomy upper third of the humerus, below the surgical neck, and in the middle of the humerus you can do, I have done, and lower 1/3 of the humerus you can do. If you want to do corticotomy, you make a stab incision, it's little bit, stop, and take your drill bit, make the even the K wire 1.8 or 2 mm, you just weaken the bone from the lateral side, weaken the bone a little bit from the anterior, lateral, and just a little bit posteriorly. You weaken the bone, and then humerus is not just like a femur or just like a tibia, smaller bone. You weaken the bone, then you take your serrated corticotope. I use serrated corticotope. That means if you put the serrated corticotope, it doesn't slip, it holds the bone very nicely. And without serrated corticotope, you can do even the osteotope a little bit. And we have a special type of corticotope. You can do that and just hit the bone and do the corticotope. Very simple.
Okay, sir. Oh, that's
Okay.
great. That's great. Okay, so that's good. Sir, we cannot cut the bone
I
through and
don't know.
through. There is a sound there. We cannot cut the bone through and through.
So don't need. If you cut the 2/3 bone and just twist, then you will be able to do you will understand there is a little movement here in the bone. Then you will be able to understand that you have done the right way in the corticotomy. I don't know whether I have finished my lecture. It was visible or not. Lastly, I was disconnected.
No, sir. You have just finished your lecture, and lastly, you were disconnected. You show all the things to our doctor.
Okay, thank you very much. And I don't know whether it was nicely visible or not.
Yes, sir. That was excellently visible, and that was a magnificent presentation also.
Thank you very much. Thank you very much.
Thank you very much, sir, for your nice presentation and highly academic information, and also Professor Navikam, sir, for being with us and sharing his valuable knowledge with us.
We had all the cases we cannot show. These are just particular cases. Sorry, I have one important.
And doctor, I can a little bit explain about my experience level of corticotomy. This is depend how many centimeters you have planned for lengthening. For 4-5 centimeters enough one osteotomy. If you have planned for 8-9 centimeters, better to do bifocal lengthening. And very important, upper part, place of fixation of muscles, musculus deltoideus. And only imagine what will be if you will do osteotomy up and 8 centimeters lengthening this area, or if you will do corticotomy below the tuberositas, and muscles will go down. And in this case, better if you will do osteotomy through place of fixation or muscles, deltoideus. Give me chance, a few slides, next time I will show. Because, including Dr. Barry, when you disconnect, I explain about very heavy case when young doctor who start both of humerus, patient with achondroplasia, lengthening 6 centimeters and too high, very high, and musculus pectoralis was below the corticotomy. And just now, which difficulties the patient has, but doctor already finished. And just now must invite a plastic surgeon, open and dislocate place of fixation of muscles. And next time, few slides I will show both of these kids.
Definitely. Sir, I want to end up this session today with your kind permission. And thank you, Professor Mofakarul Bari sir, for his nice presentation, and Professor Navikov sir for his academic discussion with us. And I would like to thank RajTV for giving us a scope to arrange this type of academic program, and definitely Renata Pharmaceuticals Limited for sponsoring this program. I'm Dr. Mohammad Tanvir Ashraf, on behalf of Orthopedic Solution Academy, saying bye-bye to all of you, and I hope we'll see you in the next Friday with another important topic, and definitely the live show from Kurgan. So stay with us and have a nice and safe day. Bye-bye.
You are watching RajTV, Jagorone, Bangladesh. Please